elastography uses ultrasound imaging modality to detect and visually record shear deformation of a tissue by the shearing forces of an ultrasonic waveform and the elastic restoring forces of the tissue against this deformation. Two types of shearing effects may be observed: simple shear that displaces a single dimension of a tissue body, resulting in simple shape deformation, and pure shear that displaces a whole surface of the tissue body, resulting in horizontal expansion of it. In clinical practice, ultrasound elastograms may be illustrated as static images of the tissue strain, usually under the term strain or compression elastography, or as dynamic tissue displacement measurements. This latter method comprises various techniques that are commonly grouped under the term shear wave elastography and offer the capability to quantitatively measure the shear wave properties. Large hard lesion on the peripheral zone of the prostate, decoded as a dark blue. Please note that there is also disruption of the capsule. A Hitachi high-vision Spyros machine was used with an intracavity probe performing at 8 to 4 MHz with tissue harmonics and compound imaging in B mode and the Hitachi real-time elastography technique. In a period of 10 months, 153 consecutive male patients have been enrolled. All patients had a standard B-mode transrectal ultrasound scan followed by a color Doppler scan and real-time compression elastography. The B-mode transrectal ultrasound findings were categorized as Type 1 no focal lesions, Type 2 ill-defined focal lesions, Type 3 definite focal lesions. Elastic properties of the peripheral zone were classified as Type 1 normal stiffness, Type 2 inhomogeneous inconclusive stiffness, Type 3 definite focal lesions of increased stiffness. Intact prostate fibrofatty margins capsule was illustrated as an orange-red rim in the RTCE images. On this elastogram, you can see hard lesions at the transitional zone, normal stiffness of the peripheral zone, and normal stiffness of the capsule coded as red. Hard lesion at the peripheral zone coded as dark blue and disruption of the capsule. Ultrasound-guided needle biopsy was then performed. In 122 patients, 12 core biopsies were taken. The rest 31 patients had 6 to 8 core biopsies. In both B-mode and RTCE scans, Type 1 images were interpreted as negative, Type 3 images were interpreted as positive, and Type 2 images were interpreted as inconclusive. Ultrasound findings were compared to the results of the core biopsies. As you can notice in these results, B-mode transrectal ultrasound inconclusive exams were twice as frequent as RTCE inconclusive exams. 70%, 10 out of 14, of these B-mode transrectal ultrasound inconclusive exams were RTCE true negative. In this table, sensitivity, specificity, positive predictive value and negative predictive value are summarized for both transrectal ultrasound and real-time compression elastography. Obvious improvement is achieved by real-time compression elastography. Disruption of the normal prostatic capsule red rim in RTCE was found in 11 patients, 73% of the 15 cancer patients that were histologically proven to have neoplasia extended beyond the prostatic capsule. Both elastography techniques have their limitations. When transrectal ultrasound is combined with elastography, diagnostic accuracy is increased. One of the advantages of compression elastography is its ability to assess integrity of prostatic capsule. Not all cancers are hard, and not all hard tissues represent cancers. Benign conditions such as chronic infection can form stiff areas. Real-time compression elastography improves the diagnostic rate of transrectal ultrasound in detecting peripheral zone prostatic cancer. In particular, it yields more robust information in the presence of cancer lesions. It can discriminate the inconclusive results of baseline B-mode images. Thus, the number of needle core samples may be reduced. It may enhance the role of transrectal ultrasound in prostatic cancer local staging.